Okay, good morning. Welcome to Grand Rounds. Today, as you all know, we have a special visiting professor, Dr. Chris McCulloh, and I am going to invite Dr. Kia Washington, our Vice Chair of DEIA, up to give the formal introductions. But before I ask her to come up, I just want to thank her, Brian Shimamoto, and many, many others in the Department of Surgery who over the last many years now have really led the efforts to make us a better Department of Surgery and to make us more diverse and more inclusive. And with that, I'm going to invite Dr. Washington up. Thank you.
Good morning, everyone. It is my great honor today to introduce Dr. Chris McCulloh. 15 years ago, he planned to enter medical school to fulfill his dream of becoming a surgeon. Instead, just months before he was to start medical school, a freak accident left him with both legs paralyzed at age 28. Undaunted, he deferred entering medical school for a year, undergoing surgery and spending months in rehab. At Case Western Medical School, an encounter with a neurologist who worked with children inspired Dr. McCulloh to shadow a pediatric surgeon during his surgery rotation. By the end of the month, he had found his passion. Dr. McCulloh completed his surgical residency at the Morristown Medical Center with the assistance of a specialized wheelchair that allows him to stand and helps him perform 5 to 6 surgeries a day. Today, he is the Associate Director of Clinical Initiatives at Active Surgical. Active is focused on enhanced real-time visualization capabilities for surgeons that combines advanced augmented reality, artificial intelligence, and machine learning technology. Again, it's a great honor to have Dr. McCulloh today. Thank you.
Thank you very much for that introduction. Really great to be here. Thank you, everybody, for having me. I want to thank again Brian and everybody else who's put this together, and Dr. Diaz-Miron, who was the person who actually made the connection through some mutual colleagues that we have. We're having a little issues with the notes, so I'm not going to move around too much because I want to be able to glance over at them from time to time while I'm talking, and they're really super small on the screen. So I've been pretty active in the online and social communities. I run a Mastodon server for disabled people. We've kind of moved, a lot of people have moved over from Twitter after everything's kind of changed since Elon Musk took over last year. In medicine, you know, as you all know, we talk often about the Swiss cheese model of patient errors and safety issues. And my story is kind of the inverse of that. I had a lot of things that worked right, which is not the case for a lot of people. So what I like to do is just talk about my story and my experiences and interweave that with those of other people that I know and kind of tell you the things that potential roadblocks and stumbling blocks that disabled patients and learners and residents face along the way. So let me tell you a little bit about myself. Maybe the clicker is not working. Oh. That has to go up there. There we go. So that's my hometown. I was born and raised in a small town called New York City. When I was growing up, I developed a passion for technology and medicine early on. My best friend's dad was a plastic surgeon growing up, and we used to sneak into his office and watch videos of open heart surgery when we were in 3rd and 4th grade, and I just thought it was the coolest thing ever. But I also developed a passion for technology at the same time, and I started working in the mid-90s in high school for, no, it's fine now, yeah. Just had to click on the actual screen up there. So I started working for an internet service provider in the mid-90s, running all their servers when I called them and told them their servers were broken, and they called me back and asked if I wanted a job. And I moved on to college, originally planning to go straight into medical school, but it was the late 90s. I fell into a job working for a .com, managing their technology, and kind of decided to stick with that for a little while. I had some opportunities that I thought were going to really be once-in-a-lifetime opportunities. So I created a company with a few colleagues back in 2002. It was called Syntamore, which one of my original partners That was his family's Gaelic crest. The words Sine in Timor meant without fear. So we proposed security without fear. I got the chance to travel the world. I spent 6 months living in Munich, working on a project for people. I contracted to McDonald's. I was an expert witness for the United States Department of Justice. Really got to do some things that were incredible. But I'd often told a number of my friends that I figured I was going to go back to medical school plan at some point. And one night on a business trip, that's exactly what happened. I checked into the hotel and felt this strong urge, and I registered for the MCAT that night and started planning how I was going to prepare for it. And this already brings up the first issue that faces a lot of disabled students and learners, which is testing and accommodations. For me, everything was fine, but that's not the case for a lot of people. So this is Jerusha Mather. She is in Australia. She has cerebral palsy. She'd wanted to pursue neurology ever since she was a kid. She had fought for accommodations for their equivalent of the MCAT. Normally in university, she had required double the time and split her exams across 2 days. And they refused to give that to her, even with the support of her physicians and her faculty at the university. They would give her an extra 25% of the time, and that's it, all on the same day, which she had done that before in high school testing, and the results were not good. So they refused to give her any of the accommodations. The people in the university openly told her, you should probably just consider another career. And they basically told her, you're not going to be able to do this. She fought the technical standards, their equivalent, the Australian equivalent of technical standards. She's actually involved in a lawsuit right now to try to bring more accessibility to the healthcare education system within Australia. She's now a PhD student. She has a lab where she's doing research in stimulation technology for people with central nervous system disabilities. And so those technical standards are a big challenge. To that end, there was a report commissioned a few years ago by the AAMC looking at inclusion and disability and barriers. And I do want to, I'll mention this several times in the talk. This was put together by a very good friend of mine, Dr. Lisa Meeks, who actually used to be here in Colorado at CU, and she's now back in Michigan. They've identified a number of barriers. They did interviews, they did research, they did all kinds of things. And they referenced a number of challenges and structural barriers that learners with disabilities would face. One is uninformed disability service providers. I was lucky enough to not have that. The people I worked with were great, but that's not always the case. A lack of clear policies and procedures. A lack of access to knowledge about nuanced clinical accommodations and assistive technology, a lack of access to other meaningful accommodations, failure to publicize technical standards and provide information on accessing accommodations. So this was the result of a study on hospitals and medical schools within the United States. And those technical standards really are the things that people are most scared about. Again, technical standards that don't reflect current technology and developments in medical practice. Lack of access to healthcare. The LCME publishes guidelines and standards for what they mention for technical standards. The big change that's in here is that they actually have added with or without reasonable accommodations to this component. And that's only something that's happened over the last couple of years. The expectation is not that somebody should be able to do a job that they can't do without some kind of accommodations, but just that those accommodations need to be provided. And there's different domains across all of that. The Colorado policy is pretty good. It's the most detailed, I think, that I've ever seen. It goes into a lot of other details and things that other places don't get into. The overarching, it's a several-page document, so I'm not going to go through with it. Most people, it's just a few statements here and there. But what this does is it highlights some of the things that the AAMC has identified as being critical to the success of disabled learners, which is an openness to disability in admissions, peer support networks and physician mentors, and a top-down commitment to diversity. And that's really one of the keys. So the openness to disability is something that I experienced, fortunately. As Dr. Washington mentioned, I was at Case Western for medical school, and to get back to my story, I applied early. I applied before I was disabled. I interviewed early on the first day. I got my acceptance on the first day. I was working, managing a team of 8 engineers. Everything was going great. I was about to go to medical school. Life was perfect. And so you can kind of guess where this is going. On Sunday, January 27th, 2008, in my apartment in Park Slope, Brooklyn, I slipped on a hard wooden floor and fell and came crashing down with my neck landing on the edge of a very thick, hard glass coffee table. And I thought this was a freak accident, 1 in a million, and I got to rehab, and there was another guy there who had the exact same mechanism of injury. He stood up from his dining room table. He was doing his taxes. So when people say taxes will be the death of you, they actually could be. As you all know, that's a very nice spinal cord. When they put me on the table and did imaging in the hospital, that's what mine looked like. So C7 had actually popped clear out of my spinal column and was lodged between C5 and C6. So they put me on the table. It was an 8-hour procedure, had to do an anterior and a posterior cervical fusion, during which I was, of course, flipped over in the middle of this procedure, wound up with a bunch of screws and plates in my neck. And the one thing that I remember most from that admission was being in the ICU, extubated, but awake, but in so much pain that I tried to convey the pain that I was in by ripping out my central line in my neck. Now, I didn't manage to pull it out. They stopped me before then. But in that state of delirium, that was the only thing I could imagine that would communicate to them how much pain I was in. So I was there for a couple of weeks. I was transferred to rehab. I did rehab at Mount Sinai. And this kind of gets into another access issue for patients, which is access to top-notch care. So there's something called model systems for spinal cord injury, and they're the places that they're designated as being sort of the best of the best. They're doing active research. They're very clinically focused on improving the lives of people who are disabled with spinal cord injury. There is one of them in Colorado. It was the Craig Hospital in Colorado. And I was lucky enough to have access to that. But when I got there, it was sort of, can I still go to medical school? I mean, can I be, who ever heard of a doctor who's disabled, you know, like, can I be a surgeon? They had stories on the wall at Sinai, sort of, you know, inspirational, get back to life stories of different people. And one of them was a neurologist who had a spinal cord injury, and he worked at Cornell. And so I said, okay, I could be a doctor, but I can't be a surgeon. I mean, who can stand? You got to stand to be a surgeon. I can't do that. A good friend of mine's wife was a 5th-year resident. She said, sure, if you can get to the table, you can and move around, then you can still do it. And I thought, yeah, okay, what does she know? I mean, she doesn't know what it's like to live with a disability. I've only been disabled for a month. What the heck do I know about trying to live with a disability? I met Adam Stein. He was my physiatrist at Mount Sinai. He's now the head of rehab at Hofstra, LIJ. He was the first person who said, why can't you go to medical school? And he had some authority because he was also on the admissions committee of Mount Sinai School of Medicine at the time. So he was the first example of physician mentorship, which is so important to learners, students, residents as they're going through the process, even more so for people who are disabled or in any kind of marginalized group. So after Dr. Stein, I started looking around and I found this guy. So this is Peter Galpin, and he's a now retired plastic surgeon who was based out of Hawaii. He just retired about 2 or 3 years ago. He was injured in the 1970s in a motorcycle crash. He had to develop his own standing wheelchair. He had to have the equipment custom made for him. None of that stuff existed in the 1980s. He went through medical school. He actually got in despite the fact that he had seen his chart when he was in rehab, and then his treating physician had written in his chart, delusional, still thinks he can be a physician. And so he faced barriers all along the way. But this was before the Americans with Disabilities Act, before any of this was commonplace. So he really was a true trailblazer. And, you know, same thing, I tell a story about my uncle, who is a physician. He's a neuropsychiatrist. He had to apply 3 times to medical school because after the first 2 applications being unsuccessful, somebody told him, hey, you really shouldn't include the letter from this one person. Somebody had agreed to write him a supporting letter and actually wrote in the letter, don't accept this guy, he's going to be blind in a couple of years, which was not true. He can still drive to this day, 30 or 40 years later. But, you know, fortunately, that doesn't happen at all anymore, right? But one of the things that Dr. Galpin showed me and that impressed me the most was his persistence. So, you know, maybe it was possible. Maybe I could actually be a surgeon. So I kept working at it. I deferred entry to medical school for a year. I focused primarily on rehab. I got some function back. I can walk with a walker. It's very awkward and clumsy. And, I'm going to lose walking down the hall to somebody who's 95 years old with a walker. But I kept working at it. Case told everybody in my class about what had happened. The students on their own independently put together and had this shirt printed, and everybody in the class that I was supposed to enter signed it. So this highlights another thing, which is just peer support in general. I felt so welcomed by that community a year before I even got there. And that was huge. When I got there, I just felt that sense of belonging, which I can't speak importantly enough about. Another thing that's key for accessibility and inclusion is that the university, as the AAMC report mentions, a top-down approach. So Case did a really good job of that. So this is Kent Smith. He was my dean. And before I started medical school, about 6 or 8 months before, they brought me out to Cleveland. We met with the head of physiatry, the facilities people, everything. They said, tell us what we need to do to make sure that you're successful. They said, we'll rip out a couple chairs in the auditorium so that you can sit there if you want. We'll make sure, let's go look at all the bathrooms, make sure those are wide enough that you can use them, get in everything. So they really took the initiative and ran. And this was, 15, 16 years ago. They were willing to pretty much do anything. But to sort of get to the overall theme of things, again, this was great for me, but I'd already been accepted when I was injured. So they kind of didn't have a choice at that point. I was already admitted and I was enrolled in the university. That's not the case for everybody who's applying. This is Greg Nemanitis. He was the head of rehab at Metro Health in Cleveland when I applied. He's now the director of spinal cord injury rehab at Cleveland Clinic. This guy was incredible. He was at those meetings that Case had. He custom designed a device that I could use in anatomy lab so that I didn't get covered in, cadaver guts. And it was, he worked with engineers to do that. He also helped to facilitate a grant that we put together that helped to get some of the equipment from the Nielsen Foundation. So this grant was for a standing wheelchair, like the one that Dr. Galpin had talked to me about and recommended that I get. We got this for the university. It wasn't for me personally. So now the Case uses this to be able to recruit and teach other students who have mobility disabilities or might benefit from something like that. And what this really highlights from the AAMC's report are these structural supports, which are so important. And that's, access to accommodations, ease in accessing them, knowledge of them, and those personal networks and student organizations. When I came back to do my second look at Case, Dr. Nemanitis had a dinner at his house that I went to, that several of the other potential students went to. He went out of his way to make me feel welcomed. And I thought he was doing this specially for me because I was a patient, but also going into medical school. And then I found out he does that for everybody. That's who he is. His patients know people in his family. He really becomes a part of people's lives when he takes care of them. So through all those. So we had put together a video. This was what we'd sent around when I was applying to residency. This was in medical school using the standing wheelchair. This was the one that Case had acquired. And basically we showed them, look, you can scrub, I can get in the OR sterilely. I just use the back of my elbow on the control. This one was a little clumsy. It got better over time. But the idea was to show people that, yeah, it's possible. And I would get gowned up and get to the table, and we were just putting in, I think, a Broviac or something really simple like that. But it was to show that I could still get to the table and that I can still operate and still do the things that I need to do. And so we sent this around to residency program directors when I was applying to show them and actually give them a visualization. And we did a similar video. I'm going to kind of skip through this one, but this was when I was in residency, and I'd been filmed to be on the doctors when I was in medical school, and then on 2020 again when I was in residency. And so that was the chair that I used in residency and after, and it stands more upright. It's easier to get into. It's just a lot more functional. So this was, again, to sort of demonstrate how it works, because it really helps to see, with people's own eyes, what's possible. So, and we were doing, I don't know why it's jumping around so much. We were doing a very small procedure, but just to illustrate things. And this gets to physician mentorship. And so this is a huge part for anybody, again, for someone who's disabled, but for any marginalized or underrepresented group, that mentorship is huge. It's very hard to find physician mentors who are disabled because there's just not that many of us. Mentorship can come from a lot of places. So this is Ed Barksdale. He's a pediatric surgeon out of Case. And if you don't know him, he is a phenomenal human being. We still talk all the time. I know his family. We text each other on Thanksgiving and Christmas. And he's always been very supportive. He was the one who facilitated the video that we did in medical school to send to residency programs. And so he was a huge help in applications. He wrote letters, he made phone calls, he did everything. That wasn't true of all the faculty that I met along the way. Some people were worried that, well, what if you can't if there's a code and you can't get there quickly enough? It turns out I actually get there faster than everybody else because I have a motor in my chair, which goes 7 miles an hour with no effort. So in residency, I was always the first one there. So there were other people that I'm not going to say who or where they were, but a very senior surgeon compared it to how people would think about women applying to programs in that, oh, well, maybe she's going to get pregnant and have to drop out and then everybody else has to pick up the load. And so I mean, hearing that in 2011 was very surprising to me. When I applied for residency, a lot of places did ask the questions. It's important to have open communication. Places didn't, and that felt like they weren't taking me seriously. It felt very disingenuous to go to a residency interview and have nobody say, so how are you actually going to operate? How are we going to make this a success? Because that's a key of any situation. That's a key for everybody, frankly, not just whether you're disabled or not. But a lot of people have a hard time imagining how a physician could be disabled. I have a good friend who's a senior person managing disability for a very large university in this country. And he heard of a report where somebody called the facilities people and said, hey, I think there's been a mistake. I was just in the physician parking lot and there's also disabled spaces. There's also handicapped spaces. That must be wrong, right? Because you can't have a physician who needs, a disabled space. So this is still very prevalent. This is my program director, Eric Lazar, who is another fantastic mentor. So when I interviewed for residency, he was very direct. He was very open. He said, what are we going to do? What do you need? How is this going to work? He said, look, if you find a bathroom that you tell me you can't get into, I'll have facilities in there the next day, knocking the door down and building a new one that's wider. I mean, it was great. He really said, how are we going to make this work? That top-down commitment was huge. I tend to ignore people who tell me I can't do something for better or for worse. But he wasn't one of those people. But that's not the case for everybody. So this is Dinesh Palapana. He, at the time I met him in 2013, had been a third-year medical student, and he was injured in a motor vehicle crash. He had spinal cord injury and he had to go to rehab. And when it was time for him, he's also in Australia. Not that I'm trying to bash Australia here, but I know a lot of people there. He spent his time in rehab. When he was getting ready to go back to medical school, he had to go in front of the medical board and explain how he was going to do things. Otherwise, they weren't going to let him back into medical school. He had been described as one of the most highly skilled students that the Griffith School of Medicine had ever graduated. But when it came time for residency, the process is a little bit different in Australia. He wasn't given a spot as an intern. He was basically waited and waited and waited, and 6 months went by when all his colleagues already knew where they were going, what they were going to do after graduation. He finally was provisionally registered by their body and given an internship. And then this is kind of more of the same thing, still waiting to hear if he would offer him an internship. Now, he did get that internship. He's now a practicing ER physician. He uses a wheelchair. He's a very proactive speaker. He's a great speaker. He's a very nice person. And he's been very successful as an ER physician in Australia. So not everyone's that lucky. This is Sarah Sternlieb. She was when I met her, she was a medical student, wanted to apply to OB and PEDS. She has a congenital condition that causes her to have muscle weakness. It's never really been identified or diagnosed fully. She did not get a lot of the support that I got or some other people got. When she was in medical school applying for residency, a lot of people told her, you should just consider something else. Like, this is going to be hard. Don't do it. So she applied to 80-something OB programs, got 20 interviews. She applied to 30-something PEDS programs and got about 15 interviews. Went on all of those. She finally got a spot in an OB program, but she had very little support from the institution. They weren't willing to work with her to find accommodations. And they basically did as little as possible for her, and they did not renew her contract at the end of PGY2. So she ended up quitting, taking time for research, went back to a medicine residency, and she's now an endocrine fellow. But she and Dinesh both sort of represent a lot of the challenges that the AAMC report identifies for disabled learners, which are stereotypes and stigma, a clinicalized culture where disabled learners are treated more as patients than they are as colleagues, negative peer attitudes and restricted views on disability, leading to learners being counseled out of specialties. So they both had been. I had a few people trying to, suggest that I do something other than surgery. But, the process, obviously, their stories are very open and very obvious and very, it's very clear what happened to them. But the process, as you know, especially with a matching program, allows for a lot of silent discrimination. There's no way that anything can be proven in a lot of these cases. But I kept pushing, and I matched, and I did residency in Morristown, which is a wonderful hospital in the suburbs of New York City. This was 7:30 a.m. on July 1st, doing an inguinal hernia on my first day as an intern. Two of my senior residents came in the room just to shoot this picture. And I was like, why are you taking a picture? Do you do this for everybody on day one of residency? But it was really cool, and I'm really glad to have it now, because it's sort of, that was that huge moment. It was the culmination of everything where I'd gotten to residency. Sometimes getting there alone isn't enough. So this is Svetlana Klayman. She was a resident at SUNY Downstate. She's had a very public interaction with Downstate, so she's fine if I share her name and some of the details. She, in her 4th year in residency, she developed transverse myelitis. She became paralyzed and now uses a wheelchair to get around. And Downstate basically said, yeah, you can't come back. They didn't even have a conversation with her about how accommodations could work. I spoke to her during the course of a lawsuit. She spoke to a lot of people to prove that, yes, it is possible. And so the end result was that she won her lawsuit against Downstate. And she did eventually finish her training. But the thing is also, one of the important points is her disability, mine, for a lot of the people that I've talked about, it's very obvious, it's very visual. Not all disabilities are visible. Whether it's physical, mental, social, other issues, it's just because you can't see something doesn't mean that there isn't something there. So I had a lot of support. During residency, I did 2 years of research at Nationwide Children's doing stem cells in necrotizing enterocolitis. I applied for for fellowship the first time with a lot of support from people. This is Gail Besner. She's been a huge mentor. She's another person that I still talk to very regularly. So I was in her lab for 2 years. And then when I applied for fellowship the first time in residency and didn't match, she said, well, we're going to figure something out for you. We're going to make this work. And so she invited me back to come do a PEDS MIS fellowship at Nationwide. I talked to program directors at a lot of programs that I had applied to and interviewed and said, what can I do to make this work? How do I prove this? And they all said, work at a busy children's hospital, handle the volume, handle the load, operate, and that'll prove that you can do that. We don't, you went to a small residency program, we're not familiar with it. So I did. I did a 1-year PEDS MIS fellowship at Nationwide, and I did a 1-year surgical critical care at the University of Michigan, and before I applied a second time to pediatric surgery. And we wanted to show everybody that, yes, it's possible in a busy children's hospital. So we updated and sent another video around and showed intubating in, obviously not a real baby, but simulated in the NICU. The top middle picture is doing a case with Ron Herschel. On the right, it was a video that we had put together where I was just doing a case, and off in the corner of the room, sitting at the computer, is Erica Newman. But the video was to show that, yeah, it's possible. And he operates on kids and he does all these things. And we had photos putting in chest tubes and all kinds of stuff. And when it came time for applications, I applied, I got a bunch of interviews, and In the interview process, when people communicate, as you all know, they ask, tell us about this person. What are they like? Do they fit with our culture? Is this going to be a good fit? They ask a whole variety of questions. And despite all the letters, despite support from 2 former presidents of APSA who had written letters, a current governor of APSA, chairs, program directors, former, heads of the Association of Program Directors, that all said, yes, he can operate. Every single call they got was, yeah, but can he really operate? Despite all of this, nobody believed it. I was a boarded surgeon at that point already too. So nobody, believed it. So I tell these people's names and share their stories because I wouldn't be here today if it wasn't for every single one of them. They embody the idea of open communication, which is so important to my success and to the success of others. My experiences have been largely positive. And that's not the case for everybody. I do want to take just a minute or two to talk about some general considerations for speaking with disabled learners and for patients as well. There's a few things. Language matters. Disabled is okay. Get used to saying that. It's not a dirty word, and that's the word that most people use these days. Don't say things like wheelchair bound. Don't say confined. Don't say any of that. Like, this wheelchair is what allows me to be here in this room talking. It's what allowed me to operate. This enables me to be successful. It doesn't restrict me in any way at all. If it wasn't for this, I'd be lying in bed at home, not able to do anything. So most people don't see their adaptive equipment as restricting them or limiting them or confining them. So it's important to sort of get that language out of people's heads. It's not suffering. I don't suffer day in and day out. Does having a disability, is it all fun and hunky-dory? No, it's a pain in the butt sometimes. But I don't suffer. It's just something I deal with. Everybody's got things they deal with day in and day out. Especially as a provider or as an educator, it's okay to ask. It's okay to ask people terminology. It's okay to ask them what things are okay, what challenges they're facing. I hear a lot of stories of people going to physicians and all of their symptoms and signs are attributed to their disability, or the disability is completely ignored and not brought into the conversation at all. It's a component of people's history and a component of their health, but it's not the only thing. Those are there's always issues that making sure doors are wide enough and tables are adjustable and all those things which are really important for patients in particular. And again, not all disabilities are visible. This was a great quote from somebody who's an activist. I wish medical students were taught to be open to information disabled patients provide. It's okay for a medical student or a doctor to admit that they don't have the answer. This is more helpful than gaslighting the patient. I'm not going to read all these. These are very long. A couple of these I think are useful, but these were just general considerations that recommendations somebody had provided. I think number 1 is one of the ones that I wanted to read, which you probably can't see, but said, instead of saying, no, you can't have those symptoms at the same time, or that's not possible, that must be uncomfortable for you, or I'm so sorry, in your experience, has treating one thing first ever helped? Instead of saying, well, your blood work and imaging is normal, so you're fine. Try saying, I know it can be frustrating that we don't have the answers, but we're going to keep looking for them together. That's for everybody. That's for every patient. How many times do we have patients who don't, we can't give them a diagnosis. The labs don't show anything, but that you still have to validate their experience and the fact that they are dealing with some issues. And that's what their experience is real. And the other one I wanted to read is, instead of, there's nothing wrong with you, it's all in your head. I want you to know that you're not alone. I know right now we don't have clear answers, but you're doing a great job advocating yourself. I see you. And again, those apply to pretty much every patient, I would say. There's another quote: as a disability activist who's proud of being disabled, there's a vocabulary of identity that I can't use with doctors. They think disability is bad. It's what they want to keep you from becoming. With a disabled doctor, I wouldn't have to explain so much because we're speaking the same language. My care outcomes would be so much better because I would be understood. This gets not just to disabled patients, but to all patients. Having representation, having a physician who has similar shared experiences to you and similar life experiences is incredibly invaluable. A lot of providers discount the experiences that their patients have. There are a lot of patients who don't get counseled or information about sexual and reproductive health. People assume that if you're disabled, you're not sexually active. I have a friend who's a social worker in healthcare, and she shared an experience she had where she had a nurse that said, so are you sexually active? And then looked at her and said, I'm guessing no, huh? Considering. And that's in a major city in the East Coast. That's not, that's at a big institution. So These are, I'm not going to read all of these, but this is another sort of, someone had posted these for Disability Pride Month and just talking general information and recommendations. These are not necessarily related just to healthcare. But I think one of the important ones that I always mention is number one, outside of emergencies, there's no reason for you to touch someone's wheelchair unless asked. If we're in the way, treat it like you would anyone else and say, excuse me. If it looks like we're stuck, don't treat us like you would. Treat us like you would anyone else, and ask if we need help, don't touch. There are several points in here which emphasize that people consider adaptive equipment extensions of their bodies. So if one of the other things they mention is if you wouldn't pick somebody up and carry them down the hall, don't just go pushing somebody's wheelchair. When I was in medical school, I was going over a ramp to get into a parking lot, and somebody came up behind me and said, "Oh, let me help you." And they started to push me. They just grabbed me, and I said, "No, I don't need help." And they kept pushing. And finally, I just grabbed the wheels and locked so that they couldn't push anymore. And I very angrily made a comment to them and went off in a huff. 2 days later, I got to the floor of one of my new rotations, and that was the attending physician who and I remembered him and he remembered me. But he said, you know, I want to apologize. I thought about it afterwards and realized what I would, you know. And so we had a chance to actually like foster good communication between them. So advocacy in general, and again, this isn't really just necessarily just for disabled the community, but for all different communities, marginalized groups, is try to understand the community, talk to people in those groups. Not everybody wants to be an advocate. Not everybody wants to share their story, especially publicly. That's okay. Everyone obviously has the right to share or not share what they want. It's very hard to appreciate the day-to-day things that people go through until you become disabled or someone you know has a disability. I didn't understand or think about any of this stuff before I was injured. Eric Lazar, my program director, my 4th year in residency, I'd already worked closely with him for 4 years. One day we got to the parking lot at the same time and he saw me pulling in, and so he waited so that we could walk into the hospital together. And he stood there and watched as I pulled my chair out of my car, pulled the wheels out of my car, put the wheels on, pulled the cushion out, pulled my bag out, finally got out of the chair. And he said, "I didn't realize how much time you have to take on every little thing. Everything that you do, just getting it out of the car takes you more time." And it was sort of a realization for him that even after 4 years of working closely together, there's still a lot of things that he didn't realize about, you know, daily life with a disability. The AAMC has, to sort of go back to the AAMC, they reference structural considerations. A lot of this has to do with fostering open communication and building the right resources. At dinner last night, we were talking a little bit about some of the initiatives here. I'm very impressed to see that there's a disability focus within the Department of Surgery. I feel like that's almost unheard of. I've not heard of that in any other institutions. Some places have them at the hospital, university level. That's really about it for most. So to have that within the surgery department is, I commend you. That's incredible. But a lot of these things really are just about access and policies and reviewing technical standards, and normalizing that sort of behavior and integrating disability and diversity, making information about services publicly and easily accessible, universal design. One of the things that you find with universal design is when things are designed to be more accessible for people with various different abilities, it actually usually makes things better for everybody. You know, the focus in New York City is on putting elevators into subways. Only about 1/3 of the subway stations have elevators. Well, it's not just disabled people who benefit from that. People who have strollers benefit. People who are older and have limited mobility benefit from that. People who are carrying heavy stuff. All of this stuff is beneficial to everybody. And before the AAMC report came out, I had thought about and identified my own experiences and sort of supports and barriers, mentorship and support, as I've talked about with all these people who've supported my career. That's huge. There's a lot of visible and invisible discrimination that occurs along the way. Having buy-in at every level is huge, and that gets to the AAMC's top-down approach. So it really does have to come from the top, and that has to be built into every level of it. Adaptive equipment is not covered by insurance in a lot of settings. The standing wheelchairs that I had, I have 2 now actually that were both independent. They're often not covered. Those each cost about $20,000. So it's not a cheap piece of equipment. And where am I now? So I finished 5 years of general surgery residency, 2 years of basic science research in Dr. Besner's lab. fellowships in PEDS, MIS, as well as surgical critical care. I boarded in surgery. I took my critical care exam a few weeks ago. I'm board eligible for surgical critical care. I completed my fellowship about a year ago. I did apply to pediatric surgery a second time and did not match a second time. I was devastated. It took me months to really process that and come to terms with letting go of that part of my life, which had been huge for 10 to 15 years. In the course of applying for fellowship the second time, one of the questions people always ask is, where do you see your practice in 10 years? And going back to my background in tech and having continued to develop and do software development along the way and apply that to a lot of the research that I did, I also had studied and taken courses in artificial intelligence. And my goal had really been to build AI into surgery and computer vision specifically. So I was telling my story to Peter Kim, who's a pediatric surgeon at Brown, and I said, well, I really want to apply tech to surgery, and I want to build AI and sort of build the future of surgery. And what I didn't know at the time is that he had a company called Active Surgical, which was building AI in surgery. And so he was sitting there chomping at the bit, waiting to try to see if he could hire me. After the match, he reached out multiple times. He recruited me. I was still thinking about what I wanted to do next. I was planning to do an innovation fellowship to apply technology to surgery, but here was a chance to actually do it in practice commercially. So that's what I'm doing now. I'm the associate clinical director. I manage a lot of the research trials that we do. We're writing grants. We have about 4 different IRB studies that are currently active at different institutions. We have a device that measures intraoperative perfusion. So it uses something called laser speckle contrast imaging to measure the movement of red blood cells within the tissue surfaces. And it's an instantaneous heat map that you get. So it gives you similar information to ICG, but it's real time. It doesn't use dye. It's repeatable. You can clamp a vessel and see it go from red to blue and the tissue instantly. And we're also building out a surgical AI platform. So I'm looking at getting back into clinical practice before it's been too long. I had a good conversation with Ron Herschel of Michigan when I was last year, and he said, don't be away for more than a couple of years or you can't go back. So I've been looking at some different possible opportunities within critical care. As I'm wrapping up, I want to plug a few things. This was a great book that Lisa Meeks had put together called Disability is Diversity. It gets into medical, nursing, healthcare related learners and the different accommodations and how to build programs that are successful. I did help write the chapter on clinical accommodation, simulation, OR, and practical experiences. And then I also wanted to plug that I'm co-moderating a panel at ACS in Boston later this month with 4 different physicians as well as that are going to be speaking on their experiences. Some that have physical, some that have issues with substance use and other mental health challenges that they've faced. And one of them is a physician who operated for many, many years and then developed a disability and can no longer operate. So he's going to talk about how to still be productive and how to adapt to that. It's often said that, disability is the one marginalized group that you are not born into that you can fall into at some point in your life. And that's an important thing. We talked a little bit about that at dinner last night, how some people develop, nerve and, disc issues and spinal issues as a result of very poor posture. So everyone who's in residency, take a few minutes, take a few seconds during cases to stretch out and, make sure you're not craning your neck over doing a bypass for 7 hours, which I've done, unfortunately. It's not fun. So the main takeaways really are just the most important thing for success. And again, this isn't just disabled learners. It's effective communication. It's asking those questions. It's engaging people. It's being respectful of their life experiences, listening to them and not making assumptions about things that they've said or done or what they can or can't do. That's it. I'm happy to speak to people at any point. My email address is the bottom one. The top one is my handle on Mastodon. Thank you for the opportunity to talk and to sort of share my story and some of the others. And I'm happy to take any questions that any of you may have.
Thank you again, Dr. McCulloh, for an outstanding, very inspiring and informative talk. I think this is kind of the first talk of this type that we've heard in this forum. And we really just want to thank you sincerely, and we'll take some questions.
Dr. McCulloh, first of all, thank you so much for visiting us and delivering this wonderful talk. And, you know, I really want to congratulate you as somebody who has already accomplished so much in a relatively short career. And, you know, I think you've only accomplished a couple of chapters in this very, very long and successful book. So, you know, as you've gone from institution to institution, you know, some of it training at those institutions, working at those institutions, or visiting institutions, what do you think that the top characteristics are of the leaders,
Mhm.
as well as the cultures that enable you to be successful, or people like you to be successful?
Well, thank you for the kind words. I think that's a great question, because I've seen experiences in some institutions where there's no discussion of disability at all, which I think does a huge disservice. There was one in particular, I have one very strong memory of somewhere that I had interviewed at, where they just completely ignored the topic of conversation. And again, I think so much of it gets back to that communication, because that's it's key. I think the thing that I appreciated most about Eric Lazar when I interviewed with him was that he was so direct, and it was refreshingly direct for me, because I know that I have to do things differently. And I know that not everybody is going to buy into that. And I think it's really a bi-directional communication, because one of the things that he shared with me while I was in residency that I hadn't thought about was, I come to the table and I use this standing chair, and it does limit, I can't shuffle side to side as easily. So either the whole table has to slide down instead of me taking a few steps, or, you know, so anesthesia does a lot more work when I'm at the table moving the patient than is typical, but it's fine. But what I didn't appreciate is that because of that, it makes the experience different for the people who are teaching me. And when people have been operating for 20, 30 years and they're teaching residents, you're very used to teaching it in a very specific way. And you're looking at it from one angle, and to look at it from a slightly different angle or from a different position is very unsettling, because you know how it looks in one setting, and to look at it from a different setting is not something that most people do on a daily basis. So it really was, for me, it was a bi-directional communication, not only of what can we do better to support you, but here are the challenges that we are facing and how can we work together. So it's really forming that partnership, which is that's the biggest thing. And again, it is top down. When that comes from the top, it's so much more prevalent. There are, you know, the University of Michigan is very big on disability, and their DEI initiatives are very strong throughout the university. And that's something that you could feel. I was not the first surgeon who had been through there who used a wheelchair. Corinne Morosco was the chair of neurosurgery there for years, and she has spina bifida, so she operates from a wheelchair. One of mine, actually, the design was hers originally, and she gave me the design, and the company made another one custom for me. So it really is that system-wide approach and that focus, which I think is something that I see that Colorado is doing a lot better than a lot of other institutions. And I'm glad to see, and it's good to hear that you're asking the question of what else can we do? What can we do even better? Because that constantly reassessing is probably central to that. So.
Hi, I'm Mark Naylor. I'm the program director and vice chair of education here. I guess one question I had was, can you speak a little bit about your, you know, working with different residents, because everyone changes rotations fairly frequently, and so, you know, what were the sort of take-home messages of that? How did that work best, you know, when you were a junior and then when you were a senior and that sort of thing?
Just sort of, so how would I communicate with people that I hadn't worked with before, or sort of?
Yeah. I mean, I think because, you know, you're sort of every time probably you may have worked with them before, you may not have, and then you have a different role, etc.
Yeah, that's a very good question, and that's something I didn't get into as much as I should have in the talk. One of the things that we did when I applied for, or when I was starting my surgical rotation in medical school, is we went, and this was facilitated by Ed Barksdale. I met with the OR nurses ahead of time, and we said, how am I going to scrub? How is he going to do this? And so we worked out a plan together with them. So it was part of me getting buy-in from the people who ran the ORs and making sure that they knew that I was coming, and we would communicate ahead of time when I was going to a different facility or a different part of the hospital or somewhere that I hadn't. So I would have to plan ahead and communicate with them, usually at least weeks, if not months in advance, and say, this is what I do. This is how it works. I'd like to meet with you beforehand, and let's talk about the logistical things. That is not always possible, especially on a trauma service. Sometimes you're in a room with a whole bunch of people you've never worked with before. Over time, that gets better. By the time I was a senior resident, I knew everybody, they knew me, and they knew to just work around me in the trauma bay. But in the beginning, usually I will try to meet with them ahead of time, even if it's just a day or two beforehand, if I know the people that I'm going to be working with. But having that early communication was key. With other residents during training, it was fairly, I got to know them very quickly, so they got, used to working with me. It was mostly other physicians and nursing staff that I hadn't worked with. So getting ahead of the curve, talking to them ahead of time. Yeah.
Hi, Dan Wood. I just wanted to ask you about some of the barriers you've overcome. I'm privileged to work with groups of patients who often encounter major barriers in healthcare. You've been extraordinarily positive about your experiences through your whole career. How have you addressed barriers and helped yourself and others to overcome them?
Yeah, that's I have a little bit of an advantage there, because I have, especially when it comes to patient experiences, as an insider working in the healthcare system, I can communicate more directly with people than others, than patients sometimes have the opportunity to do. I do try to focus on the positive parts of it. There have been negative aspects of it. They're just purely physical barriers. There's an ER, and I was telling people this last night, that I'd worked in, where it was a new building built less than 15 years ago, but I couldn't go into the ER rooms and close the door because they were too small. So I had to examine patients with the door open. I'd pull the curtain closed, but it's a tiny little space. And from an institutional perspective, that's very hard to do if it's not built in from the very beginning. So those are challenges. I would sometimes have to ask to have cases booked in different rooms that are bigger. So I would have to do those things ahead of time. That's harder for patients, I think. So I've tried to, I feel like I have a little more of a sense of it going into the room, since it's something that I've lived with. So I try to just see what's happening and ask them those questions. And if I see something that's really, that really is hindering them, then I can communicate that to people that are higher up within the hierarchy. I don't know if that answers your question at all, but.
Hi, Nicole Christian. I'm one of the associate program directors. First, thank you so much for this wonderful talk. And when you're talking about some of these invisible disabilities, which I think is something that's much more common than a lot of people really realize. Yeah. One of the barriers that I think we encounter is that the trainee may be hesitant to ask for help. Yep. And are there any, in addition to trying to create a culture of openness and support and willingness to make accommodations, do you have any advice or comments maybe for some people listening, either faculty or residents who may be hesitant to ask for assistance? That's
a great question, especially within the surgery field. People are very reticent to say things that may not be visible, that they think that they are able to hide from people. And those can be, Dr. Lazar liked to always say, the thing with Chris is that I can see his disability. I know that it's there, so we can manage it and we can make accommodations and we can do what we need to. There's a lot of other residents that have things that I can't see, and that is going to make it hard for me to actually communicate and to try to address them. Every, I think, program has had stories of residents who've had substance use problems, and that's something that can be invisible, that can be very damaging to their career and to patient safety. And as surgeons, we're scared to talk about any of that. We're scared to talk about mental health issues because it's something that, anything that can be perceived as being weaker or not normal is considered potentially career damaging. So I think the most important part is, you mentioned the culture, it's making people feel safe. It's letting them know that they're the most important thing is to discuss these things so that they can be managed, rather than people being scared to come out and discuss them, because it always goes back to communication in those cases. So it's making it clear to people that there will not be, you know, repercussions. I mean, if somebody's doing something damaging to a patient, obviously that has to be dealt with. But if somebody is facing some kind of silent issue that they need to know that they're in a place where coming forward and asking for help is not going to be held against them, and that has to be seen in a positive light. So I think having stories or examples is a huge thing, and within the institution, and, you know, names don't have to be mentioned, obviously, but, you know, saying, if you are dealing with this, we can help you with this. If there are other things that you are struggling with, whether it's mental health or substance use or other, you know, sort of life-limiting physical disabilities that may not be visible, all of those, give examples of how those can be dealt with and how those will be handled. I think was very helpful.
Right, any other questions? Go ahead.
Nora, tax attendant. I have a question for you. Has anyone you've trusted as a mentor ever told you you can't do it? And how did you deal with that? Specifically, trusted mentor.
Yeah. I have been, the very close mentors that I've had have not said that. I've had people close who have said things like that. And I think, to be fair and to be clear, I don't want it to sound like the responsibility is entirely on the institution and on the department. There is a component where the individual has to say, can I do this? You know, and if I can't, for me, can I or can I not do this? And if I can, what am I going to need to be able to do this safely and successfully? So if people have said that to me, the first thing I would do, besides after saying, oh, what a jerk, is say, well, are they right? Is there something that I do need to think about? Is this, that I have to be realistic with myself? At one point when I was in residency, I had made a comment of, oh, I can do everything just like everybody else. And I can be a very stubborn person. And that was received negatively by some of my faculty because they said, well, you can't do everything the same as everybody else. That doesn't mean you can't do things. So it's still a matter of, the way I took it was, okay, I need to look at how I'm doing things and be honest with myself. So for me personally, it was very introspective to hear those things. And I said, am I being honest with myself? Because that's what learners have to do too. It's not, the focus is, there's a lot of talk on institutional policies and people, but there is a responsibility on the learner themselves. So I personally would take those comments and say, are they right? Is there something I really do need to think about? So even if I don't like those comments, they can still be helpful. Or I can just choose to ignore them and still be stubborn and keep pushing.
Well, again, I just want to thank you, Dr. McCulloh, for broadening our perspective and helping to shift our culture. We have a gift for you from our department, of our department swag. So
Wonderful.
again, we are really honored to have you.
Thank
So
you so
thank
much.
you.
Thank you very much, everybody. Very cool. Great.
Thank you again.
Oh.
This is really, really enlightening.
I know. I'm curious. Oh, there's no, I just turn off the microphone.
Great.
No.